Okay.
Alrighty, so why don't we go ahead and get started.
I was just looking at is there a handout for this? Yes.
There are a few handouts. Let's see, so on our website, same place where you registered, there are the, so let's see, you'll have the slide set that I'm about to show you, and we also have a couple of things, one of which you might already have, but I updated it, the acronym list. I did update,
okay.
added about 7 or 8 new terms on there that I didn't have from the last session, so you'll want to re-download that if you haven't.
Okay.
And there's a new timeline that I found from CMS. A couple other organizations were in on it as well, but I got it from CMS, and it's up on the screen now. The Health Information Technology timeline, and it's not a timeline like the first one. It's the one that hits all the milestones for meaningful use, that sort of thing.
Okay, very good.
So those are both available for download on our calendar.
Perfect.
So, and they're not, go ahead. Yeah, that's not something I'm going to go over exactly, but I thought it'd be a good reference. All right, so today I put together some information on the different components of health information technology as it refers to electronic health record systems. We're going to look at some things like workflow, what parts of the EHR help manage different parts of the workflow because they don't always match up perfectly. And then we're going to go over some health information exchange information as well.
How many slides do you have? Would that be worth printing, or is it the size of a book?
No, it's, let's see, the total number of slides would be 28, and if you omitted the first 2 and the last 3, you'd be down to, what is that, just 22 or so.
Okay. Can I print it a little later, or should I do that now if I'm going to want it? Will
it's really up to you.
Later?
Oh yeah, they're not going to go anywhere.
Okay, well maybe I'll just save it. Can I do that?
Yeah, definitely. I would just save it for now, and then if you need to print it, you can.
Okay.
Save a little paper. Okay, so I have nothing to disclose. And Patricia Yorman, I have you written down as present, so CMEs won't be an issue.
Okay.
And again, nothing to disclose. I'm sorry?
I registered too, which I didn't do last time.
Oh, right. I did see. I've got you printed out right here. So that's the best way to go. It makes it a little easier on everybody.
Okay.
All right. So our objectives, I kind of mentioned this already. We'll be able to outline the major components of an EHR system in an ambulatory setting. And you'll be able to identify some entities involved in health information exchange. So just a brief overview of what components are entailed in an electronic health record system would be the practice management system, your billing system, and those have been around for years and years, e-prescription, which is a little bit newer, laboratory interface, direct care devices, things like blood pressure monitors that automatically feed into your EHR, that sort of thing. Patient portals, and we talked about those last time. That's how the patient can interact with the EHR, typically in a read-only kind of situation, except for potentially being able to make an appointment straight through the patient portal without having to call in. Reporting, so the main thing here is thinking about registries, federal and state registries, being able to have your EHR send out information to those registries without having to manually manage that. And then there is data security, authentication, retention, and availability. So how your data is managed and how it is kept safe. So these are all components of an EHR system in a very top-down, big picture kind of view. So, of course, you want to be able to support your workflow with the EHR system. You want to disrupt the workflow that is currently in place as little as possible. You don't want to have your staff make a lot of changes just so your EHR can be put in place. So the best thing to do is to be able to make your EHR system adapt to your workflow as opposed to the other way around. Of course, there's always going to be a little give and take here, but that's the idea, that's the ideal. So the ambulatory process, which I know you're very well familiar with. So there's the check-in process, where you verify your appointment, update information, pull the medical record, make any printouts that you might need to, or just in an EHR kind of situation, you move this, or you add the physician's information to the patient, and you link them up so the physician has that in their workflow now. There's the moving to the exam room. So you do your vitals and you document why they're there. You do the exam, or the physician does the exam, provider does. Do your discussions, you enter all your information into the EHR, make orders, and hand out any educational documents. Of course, there's checkout, which is a follow-up scheduling and making payment, and your post-appointment duties there. So, you have to complete your documentation after the patient leaves. A lot of times there's a lot of follow-up there, and coding, filing insurance claims, getting all of your money in order. So that's from the workflow standpoint. And if you look at it from the software standpoint, from a programmer standpoint, you're looking at a practice management system that does some of those things in the last slide. So going back to this slide, you can see under the practice management, you've got scheduling, and that is going to affect your appointment verification and scheduling your follow-up, for example. Creating an in-basket for your MAs, for your nurses, and for your providers. Typically that would be an electronic in-basket, so they know what they're looking at for the day. And then of course check out. Your patient clinical summary, you'll have your problem list, medication list, recent visits and results. So that's something you're going to be reviewing, pulling the medical record, that has to do with that. And then of course the physician or the provider being able to refer back to that information in the exam room or prior to the exam while they're talking to the patient. And moving on to the next piece, which is Computer Provider Order Entry. This is where of course your provider's entering his or her orders and adding any prescriptions that are needed. So that you're talking about going all the way back here. You're talking about the moving to the exam room, and you're also talking about any prescriptions that you want to put in. So all of that is pretty much in the second bullet there. Health information exchange. That is what's used to send your computerized provider order entry out to the pharmacies, as well as to registries, etc. HIE is very important. So that is the.
Do you see it as more than pharmacy, though? Do you see it as more than pharmacy from the HIE, or is that just pharmacy? Could it be durable medical equipment companies?
Right, no, it's going to be, that's how you're going to connect with your pharmacies. That's potentially how you might connect with laboratories, if they're outside of your agency or outside of your, outside of press. You might be able to interface with the labs and get your results electronically as opposed to having to have them sent through some other manual means. That health information exchange is also used for registries, for updating those from your EHR directly into the registries themselves. They can be used also to have one EHR system, say at Press, be able to talk to another EHR system down at Rio Grande Medical Group, say in Las Cruces, who's on Sage. So it's a way to bridge the two systems, whatever those two systems are. And it can be different EHRs, it can be EHR to pharmacy. I don't think it could really be pharmacy to pharmacy, but it potentially could be. Hospital to provider, that sort of thing. It could also be used, I don't know how much it's been used for this, but it could be used as a way to interface with the patient portal. I know that the trend has really been patient portals that come with your EHR system. So you have a Sage portal along with your Sage EHR system. But yeah, no, it's very broad. It's wide open. And right now the HIEs that's how we're sharing information primarily right now between systems, because the interoperability isn't there yet. We're still trying to get all that figured out. So it's really a band-aid fix. So moving on, your clinical messaging and portals. So like I was just talking about the patient portals, you could have physician portals and that sort of thing as well, where you could at least be able to read information from your EHR offsite. I know that here at UNM we have a Power Chart. That's the EHR that we're using, and Power Chart does have an online version, and I believe from what I've been able to get into it, it's essentially just a read-only version. So you can look up your own patients and see what's going on, but you can't actually enter anything if you're off-site. And another function that you want to consider is your ASP, your application service provider, and your community. Your application service provider is your vendor. That's all that means. And you want to have your community be able to access the EHR, like through patient portals. So going along with the workflow, another very important aspect of programming these EHR systems is usability. And you can imagine how this can get lost in coding. From a programmer's point of view, the usability may not be the first and foremost thing on that programmer's mind. The programmer's trying to make the data work, trying to make all the fields, want to make sure that they have all the fields in there that need to be in there. They want to make sure everything's talking together correctly. But the user interface portion of it needs to be considered right from the beginning as well. So just a quick definition of what usability means. It's the study of the ease with which people can employ a particular tool or other human-made object in order to achieve a particular goal. So there are 6 components here, and I thought this was kind of interesting. So just a quick blurb on each one. Learnability is the ease of use on first use. So the very first time you use it, is it fairly easy to figure out? Efficiency is after you already learned it, you've used it a couple times, been taught how to use it, how easy is it after that? It's like, oh, I get it now, and it just works. Memorability, so that means after you haven't used it for a while, say you've been out for a week, you went on vacation, or it was down for a week, how easy is it to pick back up? The errors, how severe are the typical errors that are made in the system, and how easy is it to recover from an error? That may entail the system alerting you to the fact that there is a likely error that you just made, like that number didn't make any sense for a blood pressure, that just as one example, and how easy is it for you to back out and re-enter that number correctly, and does it alert you at all? Satisfaction, is it pleasant to use, or is it everything's in red and black and it just makes you angry to even look at the screen? Utility is what you would expect from a programmer's point of view. Does it do what it's supposed to do? Is it actually, are you able to enter everything you need to enter, and are you able to extract everything you need to extract? Whether or not it's easy to do or whether or not it's comfortable to do. So why do we need usability? That's pretty obvious to some extent, but it has been studied quite a bit. The intent of HIT is to increase the ease of use, safety, and efficiency, and reduce errors. It's not to make things harder. It's not to just make sure we have everything electronic. It's supposed to make things better. And of course, as you know, it's going to take a little while to get there, but once we get over this, probably the next 5-year hump here, and get people more acclimated to using computers and using HIT, and EHR systems get better and better, it is going to increase the usability. And we want to make sure that a lack of usability doesn't hinder the process at all. We're also rushing towards meaningful use. At least many entities in New Mexico are. Not everybody. Some people are just kind of waking up to the fact that it's happening and they need to do it. But you have to have HIT in order to achieve meaningful use, and therefore let's try to make it as easy as possible on people. Kind of the negative side of things, poor usability decreases user satisfaction and of course makes people more frustrated. It increases the resistance to HIT and increases the chances for workarounds. And I'm sure you're familiar with this. If a piece of software isn't working correctly, you can't enter your blood pressure or whatever it is that you need to enter in there. It won't take your decimal or something, so you put it in a comments field. Well, putting it in a comments field isn't really going to help you extract that data down the road. If you need to report that to the state that this many kids had a blood pressure of this level or higher, you're not going to be able to pull that out of a comments field. It needs to be in the correct field. So if we didn't make the system usable, then it's just going to make things more difficult in the long run. So just some examples which you may have run into in different kinds of software that you may have used at home or at work. Overly cluttered. There's a lot of websites that are like this, particularly sale websites if you're looking for a new computer or anything from a pair of shoes to food online. You get these pages that are just littered with pictures and information and prices, and it's too much information, and you need to get off of it. Poor use of screen space. There's a whole science to how to market this stuff, how screens are set up and how the human mind works with them, and you know, the whole rule of thirds, and that's for website design and, well, any print material really. You just want to make sure that you're using it in a good way. In other words, don't put your OK button off of the screen where you have to scroll down to find it. Those sorts of things. Inconsistency in design. A good example would be if your OK button is in one place on one screen, you go to the next screen, it should be in essentially the same place. Otherwise, it's inconsistent. Unsortable lists. You maybe you've run into this before on websites where you try to pull down a menu that has your state in it, and it's listed not alphabetically, but say by order we joined the union or something, and you know what I mean, and you just can't find the thing. Mm-hmm. Or you're looking for United States in the country list, and it's listed first instead of under U, and so you end up scrolling like crazy.
Or under U, and I prefer it listed first.
Exactly, yeah. The reverse is kind of what I meant. Mm-hmm. You need to be able to have these lists sortable, or at least in a logical sort to begin with. A lot of lists you'll see in several columns, and you know, oh, it's sorted by email, and I really want to look at this by last name. You click on the top of that column, and it's resorted for you. The technology is there. It's been there a long time, so it just needs to be used in these designs. Of course, if something's hard to read, that's going to make it more difficult to use. Lack of safeguards, making something so usable that it doesn't catch you when you make an obvious mistake, that's no good either. And you have bad data, and we're dealing with health information here. We need to get this right. And of course, if something's not intuitive, entering an age instead of a date of birth, or jumping from a name to a reason they're there, and then or to most, what's the word I'm looking for, to primary complaint, and then jumping back over to address or something. That doesn't make any sense in your head. You need to be able to get all your demographics done, and then the reason they're there, any medications they're on. So make it intuitive and matching workflow. So moving on to security, and this is something that, typically it's your IT professionals who are involved with the security, but really it's everybody. Anybody who logs into the system is involved with the security of this data. Anybody who views the system is involved with the security. And what you're trying to do here is balance the security of your protected health information with usability and accessibility. So obviously, yeah, we could lock all this stuff down completely, and nobody can get to it, but, well, nobody can get to it, so what's the use of the information? You make it so usable that anybody can get to it, well, it's going to be hacked, and people are going to be publishing everyone's health information online, and it's a mess. So you've got to find a balance there. So you've got risks, you've got opportunities. All of these are essentially both. So access to having electronic versus paper records. I think we all kind of know the advantages and some of the disadvantages here. It's risky to publish this stuff in an electronic format in the sense that it's more accessible to somebody who really knows what they're doing to be able to hack in and extract all that data pretty quickly. Whereas it's a little more difficult to walk into an office, even if it's closed, you break in and try to lug, file cabinets out of there full of files. That's going to be a little more of a difficult thing to do. On the other hand, electronic is typically backed up. And so if the building burns down, your electronic files will be somewhere off-site, backed up, and your paper records will not. They will be gone. So there's one way to look at it, one of many examples. There is quite a bit of public apprehension to digitizing your health information. People don't like their information to be out there available to everyone. Some people don't care, but a lot of people do. So you've got to address that, and you need to come up with ways to be able to make sure that this information is locked down as much as possible, and only the people who are supposed to see it can see it, including, of course, the patient. Your success of your system is going to depend on ensuring patient privacy. It's not going to work without that patient privacy. The patient's not going to put any information in there, and they're not going to allow you to do it. So it absolutely has to have some privacy there. And security can facilitate patient-centered care. That's one I pulled straight from the text. I guess the way I see that is if your information, your patient information is secure enough, then the patient will be more involved in their care, and they will have access to that care. The security will be tight enough, but not so tight that the patient can't get to their information. And the idea is, then we can start moving on to the patient-centered medical home kind of model. So in case you've never run into this, different pieces of security, you have your privacy, which is patient is in control of his own information. Confidentiality, which is, that means the patient has authorized these people to have access to their private patient information. And then the security is what we do on the IT end to ensure confidentiality. Nothing really to say there, just wanted to bring that up. We do have standards we have to adhere to. And these are standards that your vendors are all dealing with, of course, and attempting to comply with. You won't have a certified EHR without these standards taken into consideration. Your ISO 27001, which is interesting. Last time I looked at that, which was a million years ago, ISO 9000 was the thing. We've moved on apparently.
So it's gone from 9,000 to 27,000. Does that mean updates or additions?
I'm not really.
Does the number signify anything?
It does, but I really don't know a lot about it. I just remember working in healthcare back in 1998, and there were some entities that were governed by ISO 9000, and there were other entities governed by other rules. So it's not an all-encompassing standard, but that's from the International Standard Organization. So not all American companies comply with that one because it's international. But we all have to comply with, of course, HIPAA, privacy rule, security rule, and the HITECH Act. Now, as far as the ISO one goes, that's going to be one for the lawyers. I'm not really sure. But it's one standard we have to take into consideration, especially if you're going to want to send your information overseas or across the border. It would be good if your EHR was complying with the ISO. And of course, all the other rules that we have to consider. There's 3 types of security to consider here. Your administrative, which these are the policies. So your administration staff comes up with all this. So policies on logins, passwords, user roles. That's not actually the rules that are in there, it's the policies that govern them. So are you supposed to change them every 3 months? Does your login include your first initial and your last name, or is there some other convention there? The roles are defined, so administrative level has full rights to everything. You may have a super user level that has rights to do slightly more things than a standard user, like create ad hoc reports, that sort of thing. You have a standard data entry person role that may only have access to certain modules, like practice management, but they don't have access to enter orders. The physician will have different roles than the MA, of course, or than a front desk person would have. So you get the idea.
Yes.
So who can have access? Who determines this? Who's in charge? Administrative also covers, employee turnover. What happens when somebody leaves? Are they immediately taken out of the database? Are they maintained for a certain amount of time and just disabled? How do you handle contractors? All your password management. So you probably get an update every 3 months or 6 months saying you have to change your password now or in the next 6 weeks. That's the rule that they're talking about. And of course, monitoring and training, making sure people aren't using it for against HIPAA, and making sure that people have the training they need to be able to use the system. There also needs to be a contingency plan. That horrible situation I mentioned a little bit ago, the whole building burns down. Where's your backup? Are you going to be able to get backup in some number of hours? Can you at least access your patient data from off-site at your backup site? So, what are you going to do to get yourself back into shape? And that includes everything from your data to purchasing new computers and, on and on and on. Now, the physical security would be exactly what you think of. Door locks, keypads, the workstation security. You might have a lock actually on the computer holding it to the desk. We have a lot of those in the school-based health centers around the city here. so that things don't just walk off, because they will. Device and media controls. When a CD is no longer needed, what happens to that CD? Is it shredded? Is it destroyed in some way? Where are you keeping your backup and media and storage media? Is it off-site? Is it locked up? Is it accessible to anyone? Yeah, you get the idea. And then there's your technical security, which this is where your policies are put into place. So your unique user identification, that's your username and password. The coding that is put into the system that logs you out after 15 minutes. So nobody can just walk up to your workstation and enter something for someone without you knowing. It's the encryption and decryption, the PNG or GNP keys that you have to have in order to read the encrypted information. And things like two-factor identification, which I don't know if you've ever had to do this, but if you have to log into your computer and you have to put your key card into the keyboard slot, that's
no, I've never had to do anything like that.
No, yeah, it's becoming a little more common, but in a lot of ways it's a bit of a barrier to use, so it hasn't been really implemented widely. But in really highly secure areas, you know, if you're trying to get into, you know, a DoD facility or something, they might do a retinal scan and you have to type in your code, that sort of thing. But that's all they mean by two-factor. So getting into health information exchange. And really all we're talking about is sending the information from one system to another. That might be within your own facility, or that might be between two facilities or two entities. So, you know, the first type is within your own organization. You need to be able to have your Computerized Provider Order Entry system talking to your Admission Discharge Transfer system, ADT system, and radiology labs. All those things need to talk together. That's health information exchange. And sometimes you have to have a separate bridge piece of software that helps those four things talk together, or 5 or 6 things talk together. And that's what a health information exchange is. Now, with any kind of ideal situation, even close to an ideal situation, it's one big system, and so it's all going to talk together. You don't need an HIE. Where you really need it is when you're exchanging information from your EHR system out to the rest of the world. So, you know, the most obvious example is sending your information to a registry, a diabetes registry or something. You'd have your programmer create something like a cron job, or a chronological job, that every night at midnight would send out this particular report to the registry. It's more complicated than that, but that's pretty much it. And then the registry receives it, sends out a notification that it did receive it, and then the EHR stops trying to send it. That's kind of the quick and easy of it. But that's what a health information exchange is for. And you might do that with a registry, you might do that with any of these other pieces here that are listed. You know, what you need for a meaningful use, you know, to get the incentives is, number one, you have to demonstrate interoperability. And one way you do that is by connecting to an HIE. And we have one here in New Mexico, the nmhic.org, I believe it is. There's a link at the end. But it's the organization that handles the health information exchange in New Mexico, and it's pretty nice. It was one of the newest ones. I'm sorry, I got distracted there for a second. It was one of the first certified HIEs in the country. So these guys have been working really hard on this, and it's something if you need to be certified, or if you need to get these incentives, contact them, and they'll be able to help at least get this first one checked off for you. You need the interoperability to be able to do the rest of this stuff. So if you can connect to the HIE, then you've kind of taken care of that little step. That's why I call it the hinges on the door. So all the other things that you can connect with would be, you know, sharing data with patients, be that through a portal or just through sending something through a secure email, which some HIEs actually have included in them is a secure email system, which is nice, although it's kind of a workaround. E-prescription systems. Let's see, quality measures reporting, so your epidemiological reports to CMS or to your state, drug formulary checks, medication reconciliation, and it goes on. Patient reminders is another one. As you can imagine, a patient reminder needs to be protected enough so you're not sending something out to somebody in a text message or something to the wrong person and saying, hey, Kevin Werling, you have this radiological appointment at this time, at this place. Please call to confirm. I'm sure you've dealt with that. It's just part of HIPAA. You've got to, you know, disguise it, use first names only, and ask to just call back. And, you know, then you can screen and make sure nobody's trying to get information about that person and they're not supposed to get it. So HIE, who makes it all happen? Of course, it's everyone who deals with the system. A lot of it is the programmers, but everyone who's in there adding information, everyone who's clicking send is making that happen. So training has to happen from top down, bottom up. So specifically, who makes it happen? Your internet service provider, all the way from them. So CenturyLink, Quest, to Comcast, to whoever has your T1 line. There's a few places around the state. Down through your internal IT, your networking, and support personnel, the people creating your software. Down through the programmers of the EHR, the registries, and the pharmacy software, the people who are creating those systems, all the way down through your users of the EHR system. The people actually providing the care, entering the information, ensuring good data. Now that is essentially all I had for today, Pat. Can you remind me, are you in the hospital system or are you in a smaller area?
I'm in a hospital in Tucumcari, New Mexico.
Oh, I see.
And it's a small hospital. We have 18 beds. And we're part of Presbyterian, and I told you last time that we're doing Epic, and you thought that was a good system. It seemed to sound like you had respect for it. Our clinic, there's a Presbyterian Medical Group clinic that is already doing Epic. The hospital, it's my understanding, will start up next year, probably in the summer.
Oh, okay. Interesting. Are you going to be linked up with all the other Presbyterians, like Presbyterian here in Albuquerque, with their system?
I would imagine so. I don't... do you mean as far as accessing records, or do you mean as far as our system itself?
Well, essentially what I'm asking is, are you going to be able to look up records? Yeah, I mean, say somebody's has gone to the hospital in Albuquerque, but now they're in Tucumcari and needing care. Can you look up their records? That's kind of what I was thinking.
I'm not sure what's planned for Epic. I know we have a program called Physicians Portal, and I believe they can access medical records in Physicians Portal at other facilities.
Oh, okay. See,
so does that mean that is Physicians Portal separate from Epic, or is it embedded in Epic?
My guess, I don't know offhand, but it sounds to me like Physicians Portal is essentially an HIE or a part of an HIE where some systems may interface directly with this system, and some may have to be manually entered. But it sounds like an HIE. It sounds like a way for physicians to be able to send each other protected information in a secure way. And I'm guessing that your system is going to be paying for that privilege.
You know, that now that you even bring up these questions you're bringing up, it makes me wonder what the process is and what the difference is going to be. We have HPF, Horizon Patient Folder, and for instance, I can go on that and I can look at scanned records of patients' information for TRIG, and I'm sure it's that sign-in capability, who has access to what, because I think there are people who can sign into HPF and see any Presbyterian patient record, whereas when I sign in, I only have access to TRIG records.
Okay.
But that's scanned records, and I think we're doing away with the scanned because there might be some scanning still yet to do. But when we start with Epic, we're supposed to be each person, the nurse, the pharmacist, myself, I'm the discharge planner. I'm sure that we'll be entering that information, but I don't know what the tie-in is for outside additional information to be placed in a record if somebody isn't manually entering something into a record.
Right. Yeah, and of course we want to get away from doing the scanned records because they're not searchable.
Yeah. Well, this is all big. And Kevin, at this point, one of the things that we're doing, our clinic is already on Epic, the Presbyterian Medical Group clinic. The hospital is not. As I said, we're probably due to go live a year from this summer. But right now, we're meeting in groups to discuss our processes of, how do you get notified of this? What do you do with that information? So we're kind of early stages of sorting ourselves out, trying to perfect things so that when Epic comes along, we'll have our processes figured out and can better use Epic.
That's fantastic. That's it sounds like you're going through the process the way it needs to be done. Checking like just what we went over, the workflow that you use, and kind of formalizing that in a way so you can just say, this is our workflow, make the EHR match up. That's a really good thing.
That's exactly right.
Yeah, that's a good process. I'm glad your organization's doing that.
Yeah, and of course I'm just going along for the ride. I'm not in charge of any of this, but I'm part of the process. And I told you on our last phone conversation, for myself, if I want to be good at something, I have to understand the whole process, not just this maybe single satellite project we're doing. I want to understand all of it.
Gotcha. Well, great. That's I work very similarly to that. I like to know the top-down stuff first, and then I can focus on the details. And so I really appreciate you being here and learning this stuff. I know some of it's a little bit abstract, and some of it is a little outside of my expertise, but I think just being exposed to it can help. Like you were saying, there's a lot of people who don't even know that this is something we're really needing to move to, and it's happening. It's mandated now, and we just need to move towards this. So
in 2014, let's see, that's in red. So October 1st of 2014, what's going to happen on that day? Medicare EHR Incentive Program. Okay.
Let's see, 2014. And let's see, which date were you talking about?
October 1 on your little milestone date. It's in
October
red.
1. Reporting period begins for eligible hospitals for fiscal year 2015. Yeah. 90 days for first year of participation.
And you see the term CAH, that's Critical Access Hospital, and that's what we are.
Oh, okay, okay.
And do you understand what that means, the Critical Access Hospital?
You know, I've run into it, but I haven't, I don't remember now.
It's a designation that we have because we're in a very underserved area. And so I think our reimbursement rates are slightly higher.
Okay.
And then we're allowed to provide services that most times hospitals cannot. And for us, that translates into our swing bed program, which is the rehab, which normally is available in a nursing home. But since we have no nursing homes, our closest nursing home is 85 miles away. So we can offer rehab side of what a nursing home would offer, or we can, for a shorter period of time, we can do the long-term care. So a patient that needs a nursing home, we can provide it. There's a maximum of how long we can provide it, but we can still provide it.
Right, right. And yeah, and I would guess you'd have to limit it to some extent, but
oh yeah, we can't have them living here, but we can have them for 30
days or so.
I think it's a 30-day max.
Gotcha. That's an interesting distinction. I actually don't think I've run into that. The eligible hospitals is something I have, and they've been eligible for 2 years now. So hopefully people are jumping on board. I'm just glad they're getting you guys in now. It's 2013. We're kind of midway through this whole thing, through the original timeline anyway. I expect it'll extend, but we're getting along here, and I'm just glad we're getting some of the smaller entities in now.
Yes. Prez has a hospital in Clovis. It's called Plains Regional Medical Center. It's not a critical access hospital like we are, but they go live with, I think, in June. So they're one of our first ones to go live.
Oh, okay, okay. And they're with Epic also, I'm assuming.
And we're all anxious to see how it goes and learn from it. And we're glad we're not the first ones.
Yeah, that can be a little more difficult. There's always a higher chance of going live and then having to pull back when you're the first one. So it's nice not to be the guinea pig every once in a while.
Yeah, well, just so it's not us, I don't care who else it is.
Yeah. Well, it makes sense not to do the CAH first.
Yeah. Well, I don't know how long we've had that designation, but I think for maybe 15 years or so, maybe not that long.
Okay.
But it helps us stay alive as a provider in a rural setting.
Gotcha, yeah. I can see that.
Well, this has been good information, and I'll kind of digest it after we get off the line, and I thank you. Is there more to what your trainings are going to be? Are there other topics that you would train on related to this?
Yeah, I'm going to do another session in another month. I'm still working on the focus of that one, but I believe what I'm going to be doing is more the why as opposed to the what. So why are we doing this? Why are we moving in this direction? What's the philosophy behind it? So not so much technology focused as maybe more policy focused, more the why.
Yeah.
So it'll probably be close to the end of the month.
So I'll look for your announcement on that one.
Good deal. Yeah, check back with our calendar pretty often. I imagine I'll do it the last week of March, assuming there's some free time. And it looks like there is some time on the schedule. So I just haven't put in the time yet, but probably get that done next week.
Good, perfect. Thank you, Kevin.
No problem. Thank you so much for coming, Pat. If you know of anybody who is interested in this topic, this one specifically, I'm doing a repeat of today on Thursday at 3:30. So just so you know, if there's anybody interested, I do have at least one person signed up for it, so it looks like it's a go. And yeah, spread the word if you don't mind.
Okay, I will. Thank you so much.
Appreciate it, Pat. You have a great day.
You too. Bye-bye.
Bye-bye.